Welcome everyone to today's event, examining best practices for equitable maternal care. Today, we will be sharing ways that you can address maternal health inequities and what are some strategies that hospitals are using to challenge those and make an impact. My name is Aisha Sayeda, Senior Program Manager at the American Hospital Association, and again, welcome. We have a great agenda today. And I just want to take some time to introduce our wonderful speakers. Lydia Isaac from the National Urban League, Dr. Mukunda Abdul-Baki from UNC Rockingham Healthcare, Dr. Sarosh Rana from the University of Chicago, Dr. Sheila Maru from Elmhurst Hospital at the NYC Health and Hospitals, and Dr. Wanda Barfield from the CDC Division of Reproductive Health. Together, we will discuss the disparities in maternal health and some strategies hospitals are using to address those. Please note that this event is being recorded and slides and the recording will be available to you after the event. If you have any questions, feel free to drop them into the chat and we will get to them in the Q&A portion. I also want to make a note that this event is taking place during National Minority Health Month and Black Maternal Health Week. Black Maternal Health Week is hosted by the Black Mamas Matters Alliance. And this year's theme is Our Bodies Belong to Us, Restoring Black Autonomy and Joy. Before we begin, I just want to quickly go through some stats and facts around maternal mortality in the country today. Many of you know, in the United States, maternal mortality rates have more than quadrupled since 1987. It started off with 7.2 deaths per 100,000 live births, and now it is 32.9 since 2021. The US has the highest rates, maternal mortality rates in the world compared to when you're comparing to other developed countries. That is astonishing and problematic. In recent times, we've seen that the maternal mortality rates nearly doubled since 2018 to now, and rates are much higher in Black women. And what the sad part is that 84% of these deaths could have been prevented. There are many possible reasons of why this is happening as listed on the slide, but we're going to focus on the racial and ethnic inequities that exist today. I also want to mention another factor that has exacerbated the rates of maternal mortality since 2020, and that's the COVID-19 pandemic. And it's not just about maternal mortality. Childbirth is also more dangerous for communities of color who are disproportionately impacted by maternal mortality and morbidity. We also see many differences between Black women and white women, and then also American Indians, Alaskan Natives, and Hispanic women, as you can see on the slide. Black women are 3 to 4 times more likely than white women to suffer a pregnancy-related death. A college-educated woman, Black mom, has a 65% greater chance of a maternal death than a white woman with a less than a high school degree. And we see those numbers also in American Indians, Alaskan Natives, and Hispanic women. There's also disparities among the causes of death as well. There's prevalence of hemorrhage and hypertension, more in women of color than white women. And then this also, the disparity will also span in rural and urban areas. Since 2020, more than 100 rural hospitals have closed down, and that impacts their OB units as well. As a result, less than 50% of rural women have access to perinatal care within 30 miles of their home, and more than 10% of them have to drive 100 miles or more for services. But we see that these deaths are happening within the hospitals and outside of hospitals as well. So you can see that on this chart. 47% of pregnancy-related deaths take place on the day of delivery or 1 to 6 days postpartum. That means 53% happen after the fact, after a mom goes into their homes, into their communities. So maternal deaths are a public health issue as much as they are a clinical issue. With that stats in mind, I want to invite our speakers, Dr. Abdulbaki, Dr. Barfield, and Lydia to join on screen so we can kind of discuss why these disparities exist and what can we do about them. A big thank you to all of you for joining today and sharing your expertise with us today. Let's start talking. Let's start kicking this off. Lydia, can you talk to us about some of the trends that you're seeing, some of the trends that you're seeing or the research says about maternal health disparities we are currently seeing, and why do these exist and what can we do about them?
Thank you, Aisha. I think one of you did a really good job of setting the stage of kind of what is happening. What we are seeing in particular among Black women is a rate of maternal mortality that is, kind of unheard of. I want to say is unheard of. It shouldn't be the way it is. We are having rates that are worse than any other country that is in a similar economic state and development state than we are. Black women have rates, as you mentioned. I think it's a really good point because a lot of times people will say, oh, it's just education or it's just money. And we know that Black women of the highest education and of the most highest economic stance have rates of maternal mortality that are worse than those who have less than a high school education and are the lowest income. And so that tells us that something else is happening. And people want to deny at times that something else is happening, but something else is happening. And something's happening not only through their life course, so you can look at a life course perspective about how women, Black women in particular, are weathering. We use this term in research that was kind of coined by Arlene Geronimus when she was at University of Michigan, of weathering. And that means that as you go on, the stresses that are happening from discrimination, racism, anything that's happening, and particularly in a Black woman's life, ends up accumulating in their body. And that accumulation actually leads to worse maternal outcomes, is what her theory is. And we're seeing that in the research that a lot of people are doing on weathering. But I think there's also this issue, people like to, when we were talking about this before, we talked about the issue of, Serena Williams. She's kind of the most famous case. This is somebody who is, a multimillionaire in her own right, married to a billionaire. It is well known, she's famous, so everybody in the hospital basically knew who she was. And it's also well known that she has medical issues, including pulmonary embolisms or embolisms in general, blood clots. And still, she was not believed during her maternal process and almost died because she knew her body and she told the doctors and the nurses, hey, something's not right. I know my body, and they didn't believe her. And so this acute sense of not believing Black women, not believing that they understand and know their bodies, right? Also, this idea that there is this idea in the medical field that Black women in particular, and Black people in particular, can take more pain, it's not that big of a deal for them, that they don't need to be treated with the care and the attention that others need to be treated. And that then gets them ignored and has symptoms and processes happening in their bodies that end up being worse. And so this is a larger problem of kind of how we treat people in this country, of structural racism, of discrimination, but also of the circumstances and the contexts that Black women sometimes find themselves in, whatever their education or income classes, with access to resources, with access to the right forms of prenatal care, with access to doctors who are sympathetic and who are understanding and who are culturally humble and listening to what their patients are saying. And so we have to think largely about the systems, right? The people, the context, the environments that support childbearing women, and how those systems are failing them. And those systems are failing them by not providing the resources and the access to the resources that they need. And even when they do have access, not always believing them when they say something's not right. And it's something that we need to all pay attention to, because the experiences are different, and understanding that When this issue of non-compliance, we like to say, oh, she wasn't compliant, but do we understand the structures around her that allows her to be quote unquote compliant? It may not be that she's compliant. It may be that she does not have access to the resources that you want her to have in order to be compliant. And so we have to understand, that's why it's important, I know a lot of pushback is happening around this issue of social needs analysis and those kind of things, but we have to understand that the context that Black women are sitting in are just different. And that difference in context doesn't always allow them to show up in a medical encounter or in a healthcare space like other people do. And so being able to ask those different questions and getting a little deeper into what the issue is can sometimes help you solve a problem, a clinical problem that is stemming from a socioeconomic or a social determinants of health issue.
Mm-hmm. Thank you, Lydia. And I think you kind of talked a little bit about the next question as in what resources, how do we make them feel comfortable? It's building that connection with the providers, having that environment, creating that safe environment. Anything else that you wanted to add to that?
Yeah, I think creating a safe environment is about listening,
Right.
sometimes, and I know I'm going to say, though I'm not a physician, I have a physician sister who treats, women all the time. She's a family practitioner. And I know many times we talk about, the 15-minute encounter when you're doing something quick, or if you're lucky enough to have a physical, it's maybe 20 or 25 minutes. There's a lot going on in that small encounter. So I don't ever want to minimize the stress that physicians are under to figure out the right way. But sometimes it takes a minute to say, what's going on with you? Tell me in your own words what's happening, and listening. And sometimes listening for that thing that's a little different, or that word that she uses that sounds a little different to you or doesn't kind of work, and say, well, tell me a little bit more about that. And sometimes it unravels a larger piece of what's happening. And so in trying to get through everything, or saying, your sugar, for example, is high. Well, what's going on with what you're eating? What are you eating? What do you have access to? How can we help you get access to something differently? And using the clinical aspects to start a conversation about what's going on around the context of that mother and her family. And so it's a difficult balance, but I do think it takes a little bit more listening and a little bit more clue, almost like being like a detective. I need to find that little clue that opens up the conversation about what the real problem might actually be, instead of just saying, okay, yeah, that's fine. You need to do this, is say, oh, well, you said this. What does that mean? And I think that will help, even in a limited time environment. That little clue will open up a door that can help lead to better outcomes.
Thank you, Lydia. Dr. Abdul-Baki, you practice in a rural, I think you might have popped off. Oh, you're coming back. Okay. You practice in a rural Virginia setting. Data shows that over 100 rural hospitals have closed down. Can you talk a little bit about the emerging challenges, or even the constant challenges rural women face in maternal care? I can imagine lack of access, lack of coverage. What are some things that you're seeing?
So all of those things are definitely relevant, and I think what I've been trying to spread the word about for my patients is that all across America, since the pandemic is over now, quote unquote, there's going to be the unwinding of Medicaid. And so we are looking at somewhere between 9 to 15 million people losing their insurance. During the 3 years of the pandemic, the government wasn't allowed to disenroll or kick anyone off. And now they're going to be allowed to, and that's going to disproportionately affect women and children in rural areas, and disproportionately affect Black and Brown women. In the short time that I've been down here, 15 years, we have lost at least 9 OBGYNs. So currently I'm the only OBGYN in a 50-mile radius, and I'm not currently practicing obstetrics, because with practicing obstetrics, you need to have backup coverage and without any other practicing OBs in the area, that's impossible. So, those are some of the issues that women are facing, like literally no doctors in a 50-mile radius to deliver their babies.
I want to go to Dr. Barfield, and we can come back to Dr. Abdulbaki. Dr. Barfield, CDC launched the Hear Her campaign in August of 2020. Can you describe what this effort is, what it hopes to accomplish, and what it hopes to offer to our communities who are disproportionately affected?
Yeah, thank you, Aisha. I think, just sort of tying into what Lydia said a little bit earlier about being heard, we know that many patients feel that their concerns during and after pregnancy actually are just not heard. And we've heard stories of women who tragically passed away or nearly did due to their concerns that weren't being addressed properly. And we also know that unconscious biases that we all have can negatively impact patient care and health outcomes. So the Hear Her campaign, which can be found at www.cdc.gov/hearher, is a campaign that really seeks to elevate women's voices and to remind all of us of the importance of really listening to her concerns and acting quickly to address them. And getting an accurate and timely diagnosis and quality care can prevent pregnancy-related complications from worsening and potentially save lives. And the campaign highlights 15 urgent maternal warning signs that could indicate a serious complication in a pregnant or postpartum person, and that they may need immediate medical attention. And as healthcare providers, we really need to recognize these signs in our patients and make sure that our patients feel comfortable voicing their concerns. Now, Hear Her materials were designed with special emphasis on Black and American Indian Alaska Native communities. So, because they have some of the biggest rates of maternal mortality, as you've heard earlier. And there are also some consumer materials that are available in 21 different languages. So I'd encourage you all to just check that out on the website. And again, go to cdc.gov/hearher. I myself am a clinician. My area is as a neonatologist, and I often follow babies. And so there are these opportunities, again, to listen, even if your usual practice isn't that of obstetrics gynecology. And that also translates into those who are involved in the care, right? Family members, loved ones, those who are behind the desk at a clinic. We all have a role to play in terms of listening to birthing people. Thanks.
Thank you, Dr. Barfield. Dr. Abdulbaki, I see that you are on, and I want to jump to your question, and maybe finish your thoughts there from the previous question. But we see that 80% of maternal deaths are preventable. So what should we be doing what are some equitable practices we should be taking on in the perinatal care, in labor and delivery, and in postpartum? Are there different practices? Are they the same? Can you talk a little bit about that as well?
So I view things as looking at many layers. So it isn't just the clinician, because as a practicing OBGYN, I don't practice in a bubble. What I'm able to do is definitely constricted and constrained by what the insurance will pay for, what the hospital is allowing. So there's a lot that goes into it. I think one of the biggest things that we as a nation really need to be looking at are the, I think it's 10 or so states that still have not expanded Medicaid coverage. Since you already know that more than half of the deaths occur after a woman goes home, that's a very key, important time to be able to access her and for her to have access to healthcare. And the states that are still not expanding it are some of the states with the worst maternal mortality, such as Mississippi, Alabama, Florida. So I think as a government, as a federal government, I think we really need to look at, if we're saying that we want to decrease maternal mortality, especially African American maternal mortality, then we have to really look at some of these places that aren't really providing adequate healthcare or resources. I think another aspect of it is the clinician, the doctor, the midwife, whoever you see, really plays a very limited role. Like, we definitely can look at cases like Serena Williams or any, a lot of times the maternal mortality, it sometimes seems like it's, oh, this happened to this one physician, but a lot of these things are operating within systems. I can tell you that for one of the moms who just died in our community, actually on January 1st, I think that, she had a C-section. Because we don't have obstetrics in the area, she traveled approximately 50 miles outside of the area to deliver. And then when something happened, and I don't know all the specifics of the case, but I think it was a preeclamptic emergency. When something like that happened, she really felt like she had no one to call that was local or nearby. And so I really do think that a bottom-up approach, where we start to really look at the resiliencies and the knowledge that exists in communities and start bringing them to the table, as opposed to being focused on everything being academic and everything being clinical. Because in a lot of situations, there really wasn't, like in that particular situation, there wasn't anything per se that the clinician did right or wrong. As far as the doctor was concerned, that lady left the hospital healthy with a healthy baby, but what she didn't have was connections in the community for someone to go out and take a blood pressure, for someone to come and check on her and the baby to see how they're doing. And so those are the things that I'm looking at. I'm looking at a larger response from the federal government around some of these states that have the worst maternal outcomes. And I'm also looking at enriching the community to address some of these deficits.
Thank you, Dr. Abdul-Baki. I know in the interest of times, we have to move on to our other segment, but one last question for all of you is, what do we need to do differently now? We know the stats. We know that we have to look at racism. We have to identify patients' needs, meet them in the context of their lives. But what are some actionable steps that our attendees here can take back to really put a dent in those numbers? And those numbers obviously are not going to change in a day. What are some short-term, long-term suggestions from all three of you that our participants can take back to improve maternal health equity? Dr. Barfield, can I start with you? You're on mute.
Hospitals and health systems really can play an important role in terms of coordination and encouraging cross-communication and collaboration amongst healthcare providers. So first, we can work to put systems in place for quality improvement, to really improve the development of quality care before, during, and after pregnancy, and really think about how we can standardize approaches so that we can respond to obstetric emergencies. And, training for providers is also really important. You can train a non-obstetric provider to consider recent pregnancy history when triaging patients. I mean, simply asking that question is really important. Have you had a baby within the last year? Also thinking about trainings on diversity and shared decision-making, cultural competency, and implicit bias. That's really important components to address disparities in healthcare and health outcomes. And you can also think about how, if you're currently doing these things, how can you model that for others? And there's opportunities to think more about this in thinkculturalhealth.hhs.gov. And we know that racism and unconscious bias leads to health disparities. across the spectrum of outcomes. So it isn't just, issues of pregnancy and postpartum. So it's really important for us to be conscious about how these biases translate to patient care and health outcomes. And, ACOG really suggests that recognizing stereotyping patients using presumed cultural beliefs can negatively impact patient interactions, especially when the patient's behaviors are attributed solely to individual choices without recognizing the role of social and structural factors. And also providing access, for example, to other services such as interpreter services for all patients' interactions when a patient's language is not really the clinician's language is a really important thing in terms of ensuring quality and avoiding errors. And also think about how you're documenting the social and structural determinants of health that could influence the patient's health and the use of healthcare, such as access to stable housing and transportation needs. And then the last thing is thinking about how we can maximize referrals to social services to help improve patients' abilities to fulfill these needs. And maybe it's not just putting a phone number on a piece of paper. It may actually require hand-holding and support to get people the services that they need.
Thank you. Those are some great suggestions. Lydia, Dr. Abdul-Baqi, any quick thoughts on that before we move on to our next segment?
I guess I'd just like to throw out there that we need to understand that before a patient even gets to the doctor's office, even if I'm providing, I'm showing up as 100%, read all the research, like I'm culturally relevant, everything is great. I'm only affecting 20% of her outcome. 80% of her outcome has already been determined pretty much by social determinants of health. And so understanding where this patient is living, what her access to food is, what her financial security is like, it really is so much more than what a clinician can do. And so it really is requiring that we rethink what healthcare, medical care looks like, and really focus more on community partnerships, because as again, and this was a shock to me, really and truly, even if we got all the clinicians culturally competent, aware of all their biases, and all hospitals were appropriately staffed, even if we did all of those things, we'd only still be affecting 20% of the outcomes. Everything else that happens outside of the doctor's office is much more important, and we really need to be looking at that and how we're addressing those needs.
Thank
And
you.
Dr. Becky, I think that means we need to think about those interventions and opportunities, that the answer isn't in a clinical intervention. But I do think it is a great opportunity for clinical leaders to contribute to that in terms of our better understanding, so that the summation isn't that it's an immutable or unchangeable event.
No, certainly I don't want it to feel like that means that the clinician is off the hook, or that the healthcare system is off the hook, but having such a narrow focus on what we do in the four walls means that we're going to still be sitting here 10 years still scratching our head. And so now is the time to be really recognizing that so much of what goes on for these patients happens before they even reach us. So it's a partnership that I'm asking for, not an either or, but not for us to just narrowly focus on the clinical, because if we do that, we're only affecting 20% of their outcomes.
Agreed. Just like we learn advances in molecular biology, we need to learn about social determinants of health.
Agreed. Lydia, any thoughts?
Well, I know we're running out of time, so I'm just going to say it's a systems issue, and it's a larger structural issue that needs to be recognized. I think the points that both Makeda and Wanda were saying were that we need to recognize as clinicians, our clinicians need to recognize that it's a larger systemic problem. And if you put your head in the sand that, oh, I'm just going to do even if I'm the perfect clinician, and then that's going to solve the problem, then you're part of the problem. Because you have to understand that we have to advocate, as we were talking about before, to think about Medicaid determinations. We have to advocate for social determinants work. We have to advocate for insurance providers to pay for these extra services that postpartum and prepartum and prenatal women need. All of that is also going to be part of the clinicians. In order for you all to do your job, the best way you need to do it is by also contributing to improving these systems that are surrounding these women. And that, I think that's kind of the point that was between the wonderful conversation right there, is that it's not, don't just say, I'm going to be a perfect clinician and then we're going to solve it. You got to be part of this, rolling up your sleeves and getting rid and dealing with the system level issues also that are happening in this country. So I'll end there. Thank
you to all of you. Now I'm going to turn it over to Julia. And Dr. Rana and Dr. Maru, and they can all share some great hospital strategies that are happening in their communities today that are improving outcomes. Julia?
Thanks so much, Aisha, and welcome Dr. Maru and Dr. Rana. It's really my privilege to be here today with such outstanding leaders in the maternal health equity space. So thank you for inviting me to this conversation. Really looking forward to talking with these two clinical leaders who I think will take on the philosophy that we heard from the last panel, that it's not just clinical and it's not just community, it's how we can tie them both together to really improve maternal health equity. So rather than read both of your impressive bios, I'm going to leave it to you to introduce yourself, and just would like to start with a few minutes for each of you to tell us about yourself, your organization, and the community you serve. So Dr. Maru, I'll start with you.
Great. Thanks so much, Julia. Great to be here today. Thanks again for having this conversation and for inviting me. I am a child of immigrants. I'm a mom of twin boys, and I live in the neighborhood where I practice as an OBGYN in Queens, New York City, walking distance from Elmhurst Hospital. I lead a collaboration between a global health institute at Mount Sinai School of Medicine with the public hospital system, which may be different than in many other parts of the country. We, I think, are the largest and one of the few remaining public hospital systems in the country. We have a close collaboration in kind of global local health. And the reason that we have that collaboration is because we serve an incredibly global community in Queens, which is called the World's Borough, where about 60% of our population is born outside of the US. More than half prefer a language other than English. And they also are a global community with very complex social needs. As a safety net hospital, almost all of our patients are either undocumented or on Medicaid. And in close partnership with committed faculty and staff at all three institutions, Mount Sinai Health and Hospitals, Elmhurst and Health and Hospitals, Queens, and a number of committed community-based social service organizations, we are now working to build more robust services to address social determinants of health for this population. So kind of hearkening back to a lot of the comments that were made in the earlier segment. So I'll pause there.
That is really helpful context for our conversation. Dr. Rana, over to you.
Hi, my name is Dr. Saroshana. I am the section chief of maternal fetal medicine and a professor of OBGYN at the University of Chicago. So University of Chicago Medicine is an urban tertiary care center, and we do serve a large, predominantly Black and publicly insured obstetrical patients. And then I was just hearing to all the excellent discussion that was going on. So we are located on the south side of Chicago, and we have several of the similar problems. So we are kind of become a health desert in the past several years. A lot of obstetrical hospitals have actually closed. Our patients have poor access to care, and several of the same insurance issues and economic factors. So I'm really hoping we can talk more about this hypertension program that we have here in the subsequent discussions.
Wonderful. So both of your hospitals have taken different approaches to addressing the maternal health inequities in your communities, both of which are really important. So I want to make sure that we have time to talk about both of them. But let's start with Dr. Maru. So can you tell us about the HOPE program at NYC Health and Hospitals and what it is and why you took that approach?
Yeah, sure. So, I think as the speakers earlier spoke about, we are in a crisis with maternal morbidity and mortality. And in New York City, these disparities are even worse than the national figures in some ways, with Black women facing an 8-fold risk of maternal death and Latina and Asian women facing about a 2-fold risk. And in addition to that, in the public hospital system, almost all of the patients are women of color and also kind of facing the consequences of intersecting issues of poverty, immigration, and other similar issues. In our pregnant population, we have higher rates of food insecurity, housing insecurity, along with high rates of diabetes, hypertension, and preterm birth. And then during the COVID pandemic, we did see that there was an additional toll of loss, isolation, and the socioeconomic impacts of the pandemic. So it was in this setting that we recognized the need for providing support, advocacy, and a connection to resources for pregnant and postpartum women that we serve. So we chose the approach of doula care. So I'll just very briefly, I'm sure people are familiar with that term, but doulas are lay people who have training in birth support and pregnancy support, oftentimes in reproductive justice and parenting, depending on the training that they receive. But for us, a doula is really someone who's by your side, especially in the most intense moments of labor and birth. And she's on your side. So she can support you in asking questions, getting the attention of your providers, and kind of serving as a bridge in navigating the healthcare system. There are, some studies out there, some literature out there that does also show that doula care has been associated with better outcomes for mothers and infants, such as a more positive birth experience, shorter labor, fewer C-sections, lower rates of preterm birth, low birth weight, higher rates of breastfeeding, and lower rates of postpartum depression. Additionally, we chose an approach of community-based doula care, and that means that it's a type of doula care where doulas are from the same community as their clients and also support them with connecting them to local community resources to address the social determinants of health. So before we started this program, we almost never saw a doula supporting one of our patients in the public hospital system. So that really, kind of was the impetus for us to say, hey, this is a really important potential source of support. Let's build it.
Were there any populations in your community that you thought were the most in need of doulas or who could benefit most?
Yeah, I mean, so because, again, we have a really segregated system in New York City, the public hospital system sees a population that is undocumented and on Medicaid, and that also kind of overlaps with other issues. And it happens to also be a population that's almost 100% women of color. And unfortunately, we do see a lot of comorbidities such as hypertension and diabetes. So in a sense, it was all of our population in the public system, but an intentional approach to choose to do this program within the public system.
That's great. And so what happens when a pregnant person joins the program? Can you walk us through that continuum of care from when they enter to whenever it concludes?
Sure. Yeah. So, we, our kind of starting point was within the hospital system, but we have very close collaborations with 2 community-based doula programs, Ancient Song Doula Services and Caribbean Women's Health Association. And so if we have a client or patient who comes to us in prenatal care, and either she identifies an interest in a doula through seeing one of our flyers or posters, or her clinician, whether it's a social worker or a midwife or an OBGYN, identifies that she might be interested in a doula, they can have a conversation, and then they're put through to a referral line that will then follow up with a phone call to say, we have a set of different options for services, including other social services like have you signed up for WIC? Have you heard about this food bank? Are you interested in other baby supplies? And then if they're interested in a doula, a referral gets placed. And that is connected with our electronic health record, which has been very helpful. So the referral gets placed. The client is then notified once a match has been made with the doula organizations. And then the doula herself would reach out to her client. And the match is based on language, on neighborhood, and also on any other soft skills that might be important in a particular case. We have some doulas who have experience in different areas, like, for example, additional breastfeeding support.
That's wonderful. And so what has the impact been of the work so far?
Sure. So I forgot to mention too that the doula then follows the mom for 4 prenatal visits through labor and birth, and then through the postpartum period, kind of more intensively in the first 8 weeks. The first 2 weeks, and then spread out a bit over the following 1 year. So we are a new, relatively new program. So we started in April of last year. We have some data, which I'll share with you, and we're also kind of anticipating a fuller evaluation. So hopefully we'll have a chance to report that back to you at a future date. One of the things that we are particularly proud of, because we feel like it's really contributed to the program, is that we designed the program through the support of a community advisory board that had about 18 meetings over the last 1.5 years, and had a number of community-based organizations, community members, as well as representatives from the hospitals and local agencies. So this advisory board really gave strong input into the design, into the evaluation, and also to kind of create a network for the doulas to refer out to in terms of social services. In addition, we really realized that we had to build a workforce of community-based doulas in our borough. So part of our impact is in building that workforce. So we have trained about 20 doulas in Queens from the neighborhoods around the hospital. And together they speak about 10 languages. And we recognized we didn't have enough Spanish speaking doulas. So we just have completed, this month, we'll be completing another training of another 20 doulas to try to expand that workforce. In addition, I think you had mentioned earlier about that integration between hospitals and communities. And so another important impact that we've had is in training our hospital staff and creating a doula-friendly environment. So creating policies for doulas when they enter the hospital setting, and training our providers on what lay support looks like. And also in what is a reproductive justice framework, implicit bias people talked about earlier. So these are kind of wrapped into our doula trainings is some of these other frameworks. And then, to kind of look at the numbers a little bit, we've had from April through February, we had about 115 referrals, and we had about a 50% match rate. About half were English speaking, about 45% Spanish speaking, and then a number of other languages. And we've kind of had a mix of doulas who've matched with clients early in pregnancy, with those who match a little bit later if people enter late into prenatal care and there's a particular need, and those who prefer a postpartum doula only. So as I mentioned, again, we're kind of awaiting the results of our evaluation, which will be from 3 perspectives. So from the perspective of doulas, from the perspective of participants, and from the perspective of healthcare providers.
Well, when you get the results of that evaluation, we would certainly love to hear about it. But for now, I want to turn our attention to the Midwest and my hometown of Chicago, and Dr. Rana to talk to us about how University of Chicago is addressing hypertension as part of their maternal health equity program. So Dr. Rana, welcome. Can you tell us about the STAMP HTN program and its focus on maternal hypertension? What is it? Why did you start it?
So thank you so much. And I don't know how many people are aware, but there was a recent, we've talked a lot about mortality. So I just wanted to maybe just like one plug about morbidity. So SMM, severe maternal morbidity, is 70 to 80 times more common than mortality. So those are those near misses that we were talking about. And very recently, there was an article published last week, is that eclampsia and preeclampsia related complications are the #1 cause of maternal mortality across United States, and more commonly in some states, and definitely more common in African-American Black women. So the University of Chicago here serves, like I said, a large population of women who are at risk for hypertensive disorders of pregnancy. In fact, when we looked at our data, 80% of the women with any kind of hypertensive disorder are actually Black, and a large proportion, about 70% of them, are Medicaid, which are both risk factors to have complications. And not only their increases for complications, the actually postpartum follow-up is very poor. So nationally, if you look at so ACOG says all women who deliver with high blood pressure should have a 7 to 10 day or like some kind of an appointment before the 6-week mark. And turns out then only about 30% of the women will actually follow up. So what we did was and we'll go into what was the impetus, but what we did was we created and implemented a quality bundle that we are calling it STAMP Hypertension, which essentially stands for Systematic Treatment and Management of Postpartum Hypertension. So this is a quality improvement initiative to improve postpartum care of women with hypertensive disorders of pregnancy. So since it's a bundle, it has several components, and we'll talk about the efficacy. It's hard to say what element really worked, but it's a bundle that consists of several interventions and includes healthcare professional and patient education. We give written instructions to patients at the time of discharge and have a preeclampsia discharge checklist. We actually have a dedicated nurse educator who educates all our patients about diagnosis of preeclampsia when they're being delivered. We created postpartum hypertension clinics, which are dedicated clinics where the patients are seen for their postpartum hypertension appointments. We updated all the protocols for management of postpartum hypertension in the inpatient setting, outpatient setting, readmission setting, and we provide free blood pressure monitors with Bluetooth monitoring, with Bluetooth capabilities, and we do remote patient monitoring of blood pressures for the first 6 weeks after delivery. So we believe that maternal care coordination using this remote patient monitoring connects women to the treatment services and specialty care in the most vulnerable postpartum period. And there is CDC data that about 70% of the deaths are actually occurring postpartum, and out of that, 50% occurs within 1 week of their delivery. So really intervening in the immediate postpartum period is very important. And then we also have a component of in-home postpartum community health workers, which also support the continuity of care postpartum.
I love that you're matching the remote patient monitoring with the in-home community health workers. That's great. I know you kind of touched on the impetus, but did you want to elaborate on that at all and what was happening in your community that made you start this?
Sure. I know we are running short on time, but I think the way that there are several approaches to limit this racial disparity, especially as it pertains to hypertension. So I wrote a recent review article, but one of the things that we kind of learned from the literature is that there is hypertension education and awareness. So that could be one of the strategies. And then obviously we can talk about reducing structural racism and obviously implicit bias among the physicians. But the other two strategies that we kind of thought of it as part of this bundle was quality initiatives, so program bundles, and also innovative solutions such as telehealth and home visits. So I think we kind of combined all of those in this intervention. And impetus was the same kind of, what people have been talking about. When we looked at our process of admission and discharge of patients who come with preeclampsia, what we found was there was really general lack of knowledge among patients themselves. So they will have preeclampsia and they'll be discharged and they don't really know what their risks are postpartum. There was really no organized effort for education to patients. We really were not giving any discharge instructions. And although ACOG says bring them back, we really had no clinics where the patients will come back. And then we had a whole host of problems in the ED, where they really could not recognize patients who are postpartum. They would wait for several hours to be in the same line as everybody else. We had delayed transfer to labor and delivery. ED was really not in tune with what is postpartum hypertension. There is postpartum preeclampsia and eclampsia. And then there were no protocols for readmission. So we were really just the whole thing had to be looked at.
Absolutely. So with the new program, can you walk us through what happens from when a pregnant person becomes part of the quality bundle? And how is that really designed to address those health inequities that you've been seeing?
Yeah, so the STAMP hypertension bundle, like I said, it's a hospital-wide quality bundle. So it's applied to any patient and all patients who have any diagnosis of hypertensive disorder pregnancy. So this includes patients with preeclampsia, with severe features, without severe features, gestational hypertension, chronic hypertension, superimposed preeclampsia. Anybody with any of these diagnoses gets enrolled in the bundle. We started this actually in 2019, and we can talk about it, but we've enrolled over 4,500 women in this program. So essentially what it is, it has several components. So for example, at the time of delivery, the patient watches an educational video. So everybody with a diagnosis, they have to watch this video before they can turn on their TV. There's a little bit of a mean streak there, but it's an obligatory thing that they do. Then at the time before they get discharged, the patients are given this blood pressure monitor. They're given a written log. They download their app. We give them a wrist bracelet, which essentially is like a medical bracelet. And we schedule their follow-up appointment. So every patient gets this appointment, which is through telehealth at 7 to 10 days after their discharge. Then at the postpartum hypertension clinic, Essentially, they're all run by our physician assistants under the MFM physicians. It's about 7 to 10 days later. Here, the patients are educated again about their cardiovascular risk, long-term as well as short-term. We have protocols for management of hypertension. And then if the patient has severe hypertension anytime during her postpartum period, they actually go directly to labor and delivery. And we can talk about the escalation processes that are through the remote patient monitoring. It's very kind of automated system. And then obviously, if she gets readmitted, we have protocols for readmission. All patients are admitted to maternal fetal medicine service and managed in a very standardized fashion. And then obviously, if things are good, she comes back for a 6-week appointment. At that time, we actually schedule the appointments to follow with cardiology or with the PCP.
So it sounds like you have partnerships across the entire healthcare system. Are there community partnerships too that are supporting this work?
Yeah, so we, in terms of our partners, we have lots of, you can imagine, internal and external partners. So a few of the things that I would like to point out are our labor and delivery and mother-baby nurses. So I think of all the things that, I can think of all our partners. I think our labor and delivery nurses and mother-baby nurses are our most important partners. Then obviously all our OB providers, anybody who practices OB here and credential to deliver patients has to go through a annual competency, which was created by me, and this is mandatory for everybody to follow that. And obviously our physician assistants, we have our outpatient nurses, we have our administrators who are really good stakeholders in this program. And then we actually leveraged our IT department, the Department of Digital Health here at the University of Chicago. So the leader there is Brianna Brooks. And then we leverage we work with this external vendor called Health Recovery Solutions, HRS, which is a company that's providing blood pressure cuffs, remote patient monitoring, and they actually have a nursing surveillance 24/7 for all the blood pressures. And it's all Epic compatible, so all the blood pressures actually come through Epic. And then obviously our funding, internal and external. And the community partners are really our community health workers. So we have 2 dedicated community health workers who process the patients if they're not checking their blood pressures. We have like kind of patients that go through the community health workers.
That's great. And I'm being mindful of time, and I want to ask you both my 2 rapid fire closeout questions. So 1, what have you learned over the course of implementing these initiatives that you can share? Like, what's something you know now that you wish you knew when you started? Dr. Maru or Dr.
It doesn't matter. I can go. So yeah, one of the things I wanted to point it out, and I know somebody put in a chat box about the remote patient monitoring. So just to give you people context how effective this program has been, when we started, the postpartum follow-up among Black women was 30% and white women was 55%. So very bad, but still there was lots of disparity as well. And then now we just analyzed our data. We have 81% for African-American Black women postpartum follow-up. So it went up from 30% to 81%. And in white women, it went up from 55 to 88. So we are kind of eliminated disparity. And we published this couple of papers now, the significant reduction in blood pressure. So I'll just say one line about what I learned. I think communication and having reliable processes such as high-risk huddles and debriefing. And I think personally for me, I feel we should post the process. So if you're doing some of these things, pocket notebooks, bulletin boards, posters, food, networking, publication, I think just getting the word out there, what you're doing, I feel is something that's important.
That was great to hear about your work, Dr. Anna. I really appreciated that. I guess one quick thing would be just that this type of work in terms of building bridges and breaking down walls between communities and hospitals opens a line of communication. And just by having that communication line open, we've learned so much about the culture of our labor floors, about our clinics. And I think it is an opening that can have so much potential for improvement.
All right, and last question in 1 to 2 sentences. What's your vision for the future of pregnancy care in your community? Dr. Maru, go for it.
Okay. Yeah, I think I want what a lot of people here want, which is healthy moms and healthy babies and equitable care and trust in our health system. And yeah, I think that's it.
Dr. Rana, last word goes to you.
Well, I would say if you want to summarize in one sentence, I would say I want to improve the care of women who are living in the South Side of Chicago.
Wonderful. Well, thank you both so much for being here and for sharing the really essential work you're doing for your communities. We so appreciate it and applaud the work you do. Thank you. I'm going to turn it back over to Aisha for just some closing words.
Yeah, thank you so much, Dr. Rana, Dr. Maru, and Julia. This was a great conversation, and thank you to Dr. Barfield, Lydia, and Dr. Abdulbaki for the earlier part of this event. All of these insights have been so amazing, and I hope that we can all take something back to our healthcare organizations, to our community organizations, and really think about how can we bring hospital, health systems, communities together to really improve outcomes for moms and their babies. So with that, I want to share that we will be sharing the recording and the slides with all of you, along with some resources that the AHA has, so that you have some case examples, some podcasts, and all of that good stuff to go back to and learn more about what other hospitals are doing to improve the lives of moms. So thank you so much for joining today, and I hope you have a good rest of the day.